do than listen to me at 7 o'clock in the evening. But I hope I can actually say some things that resonate with you. I'm going to try and share my screen with you now, which I hope will come up. It was working earlier when I was talking to Bob, so hopefully this will now actually appear on your screens. Okay, so I'm Lesley Fallowfield, and I am the director of SHOREC, which stands for Sussex Health Outcomes Research and Education in Cancer. And that's what we do. We measure things like quality of life in cancer treatment trials. We work on interventions to try and help patients deal with the worst side effects of otherwise efficacious treatments. And we do a lot of work trying to help patients understand the information that their healthcare professionals are giving them. And to that end, we run lots of evidence-based communication skills training programs for doctors and nurses and other healthcare professionals. One of the things I think that's happened over the last...
That is no good, is it?
Sorry, you can't hear me? Hello? Somebody's saying...
Leslie, I can hear you fine.
I'm trying to figure it out.
I can hear you.
And can
Yeah,
you...
I think if whoever's not on mute, can they please just go on mute so we can listen to Leslie? Thank you.
And can you see my slides okay?
Yes, I can see your slides and I can hear you.
Okay, that's great. So one of the good things that has happened in the world of cancer over the last couple of decades is that we've got much better understanding of the science that underpins a lot of the different sorts of cancers that there are. And we've got lots more treatments that are more likely to be helpful. The problem is that this makes it terribly complex and complicated to explain to people who are trying to make decisions about what to do in terms of treatment, policies, and so forth that their healthcare professionals might talk to them about. So I've been asked by Bob and your colleagues to do a presentation on getting the most from your consultation, the specifics of doctor-patient communication. As I said, we run a lot of communication skills training programs. So some of this is totally relevant to WM. Other bits are more generic.
Yeah.
So the first thing I'd like to say is Waldenstrom what? I mean, it is such a strange area because, of course, it's a very rare cancer. So very few people will have heard about it, let alone be able to pronounce it very comfortably. In this talk, I'm going to focus particularly probably on the initial diagnosis, that consultation. I'm going to throw in quite a bit of psychology about the normal reactions and memory when one is in a consultation that's going to have complex and sometimes quite difficult information. I'm very sorry, everybody, but do you think you could all go on mute? Because I keep picking up comments that people are making and it's quite difficult to focus. So if you wouldn't mind going on mute, that would be really helpful. So I'm going to focus on the initial diagnosis, talk a little bit about the psychology of the sorts of reactions that you might be having that actually influence memory, throw in a few practical tips that might help, and talk about things as time goes by. So thoughts during the initial diagnostic consultation. What on earth are they talking about? I can't remember all these words. Oh my God, am I going to die? They don't seem very sure what to do. What on earth am I going to tell the family? So those are the sorts of basic headings I'll be dealing with. So what about what on earth are they talking about? As I said before, there's a whole plethora of different concepts and ideas that will be complete news to somebody. Many doctors become inured to the sort of medical terminology that they're using, the jargon. And over time, some of them don't always recognize when they're doing this, which can be very confusing for you, the listener. I think it's really important to try and be brave enough to interrupt and say when you don't understand, because if the consultation goes too far along with lots of stuff and words that you haven't actually grasped, you're going to go home with a very odd view of what lies ahead. Not only are most patients and whoever might have accompanied them to a consultation going to be dealing with lots of strange, complex information, strange ideas and terminology, all this is going to be set against a backdrop of quite natural fear and anxiety, which makes things often quite difficult to remember. We've done lots of work with healthcare professionals working within various cancer areas, and many of them are quite happy now for patients to actually record the consultation. This has got many benefits. I mean, most of us have got smartphones or can get access to one. And it really helps if you can listen back to what's been said, maybe share it also with family and friends so that they've got a better view of what on earth has taken place. Obviously, this is a pretty basic, but having a friend or relative that you trust to accompany you who can write things down is also often helpful. But you can help the doctor quite a bit as well by coming prepared. Every doctor is going to ask you quite basic questions, such as when different symptoms started, what drugs you're taking for other things, how you're doing with different treatments that might have been given. So write them down and bring them along with you. Now somebody has started sharing their screen, somebody called Sue Sharp, which means I can no longer see my screen. So whoever Sue Sharp is, can you stop sharing your screen, please?
Sue, are you there, Sue Sharp? You've brought your screen up.
Can people? I hope people can
There you
now
go. There you go.
mine.
There you go. Yeah.
Okay, thank you. Right. So yes. So make sure you've actually done a bit of preparation before you go along. Okay, I've now got a problem because I think somebody has still got something up, which means, okay, I'm back. Okay, now many things are going to influence an individual's decision-making. Numeracy, the meaning that you attach to the various medical statistics and numbers that people give, understanding the information and your own attitudes to risk appraisal, in particular, the tolerance or intolerance that you as a person have to uncertainty, your own sort of anxiety levels, and general coping strategies. So under the what on earth are they all talking about, so I can't remember all these numbers, many of us have quite a lot of difficulty with figures and numbers. Maths anxiety is very common in even quite well-educated populations. Many consultations will involve lots of numbers and percentages, which get a bit muddled and mixed up. There's something known as denominator neglect, which means that when lots of different percentages or numbers are given in a consultation, particularly if somebody is feeling quite anxious, they're likely to start ignoring the denominator and just listen to the various numerators, which means they will often go out of a consultation with some very bizarre ideas. So if you're not great with numbers, always actually ask for clarity and ask the doctor to express things in slightly different ways. We also know that if doctors describe the treatment benefits from any treatment or drug or procedure that they're about to talk to you about, if they talk about these first, Then they actually talk about the risks and harms that might be associated with them. People are more likely to overestimate the harms. Now, I want to show you something to just, if you like, illustrate that. In a study, 2 groups of people were asked to imagine severe headaches that were so bad that would make them miss work. They were then told about an exciting new drug that had been shown in clinical trials to reduce headaches, but which had side effects. Now, half of the group were told 10 out of 100 people would get a bad blistering rash if they took this drug, or the other half were told that 10% would get a bad blistering rash. And something interesting came out of this. Those participants who weren't that great about numbers thought that the drug was much less risky if the information was given as a percentage. In other words, whenever they were told that 10% would get a bad blistering rash, rather than 10 out of 100 people would, even though those are exactly the same things, they actually thought, oh, this is less risky, I'll have the drug. Perhaps it's because percentages, which a lot of people don't understand very well, seem more abstract, and so you worry less about them. I want to also talk a little bit more now about this problem of trying to help people understand what the benefits and risks, side effects of a drug might be. If the doctor tells you about a new drug and its side effects that worry you, but the doctor explains that headaches are fairly common, constipation occurs often, itchy rashes are unlikely, increased heart rate is very rare. Now, what do we all make of that? So the doctor will avoid saying a number, but will actually just use these verbal expressions. We asked doctors themselves to do this exercise, and we asked them, how many people out of 100 do you think, if headaches are fairly common, would get headaches? And the doctors, and these were senior doctors, not juniors, it ranged from 20 to 95 out of 100. So that's a doctor saying that. Constipation, which we told them occurred often, that ranged from 100 to 60, sorry, 10 to 60 out of 100. Itchy rashes, which were unlikely, they thought varied between 1 to 10, and increased heart rate, which was very rare, some said 1, and it ranged up to 3 out of 100. Now, the point of showing you this is that if a doctor actually picks up that maybe you're somebody who doesn't like numbers very much, so uses a phrase like, oh, well, you know, your blood count could go down quite often, or it's fairly common that we have to adjust things because your blood counts actually don't look too good. They don't know what you understand by fairly common, often, unlikely, or very rare. So we know that it's best if people give a number and they accompany it with a verbal description so that everybody's on the same page. Headaches are fairly common. In other words, maybe 70 out of 100 people just like you are likely to get them. Then you're on the same page. Now, patients are going to respond to the various sorts of risk information in various different ways. Any risk information that a doctor gives us during a consultation is going to be processed by the brain cognitively, the way you think about the information that's received, or emotionally, which will be your reaction to risks and uncertainty generally. Now, both of these things are interrelated. A cognitive appraisal of the information and your evaluation of the information they've given you will obviously give rise to emotions. And then emotions themselves are going to influence the appraisal of what somebody's telling you. And how we're going to therefore interpret things depends very much on whether or not we see our glass as half full or half empty, optimism or pessimism. So we all sort of exist on a continuum between being very optimistic to very pessimistic, or some people could say realistic, and some of us are somewhere in between. A predisposition to optimism or pessimism, though, will infect the interpretation of what the doctor is going to say to you during a consultation. We know from various research that's done that those individuals who've got a predisposition to being more optimistic generally tend to have better coping skills, greater social support, and increased life satisfaction. But that doesn't mean it's necessarily good, because they may be unrealistic when making decisions. Because they're optimistic, they might feel themselves to be less at risk than their peers and overestimate the benefits, underestimate the harms of different treatments. Overly pessimistic personality types, on the other hand, tend to be associated with higher depression and anxiety, are often more isolated and more stressed, which it leads to generally more negative health effects. But we've got to think about our own anxiety, attitudes to uncertainty, because this really will influence the decision that you make about all the information that a doctor might give you. Uncertainty is, forgive me, I'm a psychologist, a psychonoxious experience that can lead to crippling anxiety. And we know that if you have an anxious predisposition, this is strongly correlated with personal risk aversion. Depression, on the other hand, tends towards a preference for being completely passive and not taking any action. The anxious, risk-averse individual will tend to give lower probabilities for positive outcomes and higher probabilities for bad outcomes. So doctors who know a little bit about all these sorts of things, if they know that they've got a very anxious, risk-averse individual, they certainly need to think very hard about the nuance when they're describing risks and benefits to people. Now, I want to talk a little bit about general coping strategies and information seeking. How one generally copes with life's problems to reduce stress is predictive of the amount of information seeking you'll do and the amount that you want. Some individuals are very problem focused. I'm sure you would all know yourself whether you're like this. When you've got a problem, you tend to actually deal with it by trying to exert some control, doing things. So in the context of WM, if a doctor actually says to somebody who's very problem focused, a control seeker, being told that, look, this disease might not actually show itself for some time, we're not going to offer you any treatment right now, they might find that rather difficult to tolerate. Other people tend to cope by using what we call detachment or avoidance. This is rather like the classic ostrich head in the sand approach. And they might find a strategy hard if they're having constant monitoring and tests. If you usually cope with stuff that's difficult and stressful by just detaching yourself from it and avoiding it, constantly having to go to the hospital for blood tests and checks is not going to allow you to do that, and you become more anxious. Now, I want to just spend a moment talking about a natural reaction that all patients who are actually told they have a life-threatening diagnosis experience. It's a natural concern, I think, for many people when they are being told that they've got a life-threatening disease to focus on the much more emotive words such as incurable. I've already said that some people are naturally more optimistic and others pessimistic. So how much emphasis you put on these more negative words is actually going to be influenced by those predispositions. And we've already mentioned that your responses to some of the discussion that the doctor has is either going to be focused very much on the information, you're going to cognitively think about the facts and figures, or you're going to be very emotionally biased, which will in fact affect your ability to actually take in, remember and understand and process some of that information. I think it is so important, though, of course, with WM that for many, the disease will be indolent, and so people can maintain a pretty good quality of life for quite a long time. And even with many of our treatments now, provided that the doctor actually offers appropriate ameliorative interventions to help you deal with the worst side effects, people can have a good quality of life. So what are some of the questions you might need to ask? Well, obviously, what the different treatment options available are and how effective they might be. But alongside that, it's so important to understand more about the pros and cons, not just about the side effects, but the burdens. For example, is the treatment going to be an oral pill that you can take quite easily at home? Or is it going to involve you in repeated visits to the hospital for intravenous infusions? How many hospital visits are required? How many different scans and blood tests might actually be associated with the different sorts of treatment options available to you? Obviously, you probably need to talk about the timing of treatment and what would happen if you decline to have it specifically at that time. Some people will also be very, very keen to find out if there are any clinical trials of newer treatments available, and also how long you've got actually to decide, because I think that sometimes people get rather panicked by having to make decisions too quickly, and then might actually agree to something that perhaps doesn't fit well with their own lifestyle. Now, one of the problems with having a very rare disease is that sometimes you will meet people who actually do have to share quite a bit of uncertainty with you, which could actually lend itself to you feeling that they don't seem very sure what to do. It's extremely difficult for many healthcare professionals when they're dealing, as I say, with rare conditions, as the outcomes are often quite uncertain and sometimes unpredictable. It's not like common cancers like, I don't know, lung cancer or breast cancer, where we have so many clinical trials and data that it's much easier to predict who's going to benefit from different treatments. There are lots of different treatments you could offer, and what the benefits, the pros and cons are. And I think it's hard, therefore, if you have a high level of uncertainty yourself, to really sort of cope with the fact that the doctor seems quite uncertain. I would like to say, though, that all of us would prefer that medicine was a much more exact science than it actually is. It's some of the facts, or some of the things we think are facts, are actually just hypotheses that are continually being defined or refined by all the clever research that's going on. And sometimes we've just got to learn to deal with this uncertainty. I think it is important, though, to ask for best case scenarios and the worst case ones as well, so that you can always hope for the best, but be prepared for something that could be a slightly less desirable outcome. I think also one of the problems that people like yourselves have is, of course, that in common with other patients with rarer cancers, you might often have already experienced delayed or even an incorrect diagnosis. There's often a lack of disease-specific information out there, and sometimes lots of limited access to clinical expertise and trials. I think one of the things my group has seen over the years when we talk with patients is that in the context of life-threatening disease, many patients will often feel, oh, more aggressive treatment must be best. I need to have, all the chemotherapy now as soon as possible. And they'll find surveillance and monitoring to see how things just go before starting treatment very difficult to deal with. If patients don't feel very certain that their doctor seems very sure about what to do, they might therefore seek a second opinion. Actually, I think it's a bit of a myth that you've got a legal right to ask for one. You haven't really, but actually in practice, most healthcare professionals would be very unlikely to refuse. However, there aren't lots of people that you could actually be referred on to for a second opinion. Most patients would at some stage be treated within specialist centres where you do have the best experts in the country, even within our NHS, actually giving you advice. So merely seeking a second opinion because you don't like what you've been told isn't a great idea. If you don't understand what you've been told, rather than having a second opinion, I think you need to really ask for much more understandable information in a format that you can process. I just want to mention a little bit about, what on earth you're going to tell the family. Very few of us inhabit a complete social vacuum, and therefore the diagnosis and any of the options that you choose is going to have an impact on your own loved ones. They're often going to be the biggest source of support for you as well, so they need a great deal more information. But they're likely to have similar reactions to patients to the information given. So certainly when taking a relative or a friend along with you, it's probably wise to have one that has got slightly different reactions to you. If you're somebody who gets deeply anxious and nervous and can't speak, then take somebody who's more problem focused and able to intervene and ask questions. So bring trusted ones to your consultations. And again, I can't emphasize how helpful it is to actually ask the doctor if you can record the consultation and then play it back at home. It's quite interesting when I ask people, friends who aren't in medicine, what happened when they went to see the doctor. And they'll tell me something. They might actually tell me a little bit about what the, diagnosis was. They might tell me something about what's going to happen at the end. But then everything in the middle gets sort of completely muddled up. This is a phenomenon known as effort after meaning. We tend to be able to remember the first things that people say. We often will also remember the last thing that people say, but then we try and actually link both of those things up, which is why very often people give me a quite garbled sort of account of what the doctor said and why they're going to suggest one thing rather than another. And I know that no doctor would have said what the account is. This is because people cannot process the volume that they're given in a way that we would like. So that's why I'd really recommend playing recordings of your consultation. A few other issues before we bring this to an end. You're obviously going to meet many healthcare professionals who are experts in hematological disease, but they're not experts necessarily about you. And what fits one patient in terms of treatment or surveillance or monitoring might not fit with your own personal preferences. And I think it is important for you to share that information with the doctor. The other thing that I think is so important, especially if what the doctor has told you hasn't really sounded like it resonates exactly with your expectations or what you might prefer, please beware of the well-meaning friend who's consulted Dr. Google or has found a miracle cure online of various herbs and diets and things. Your doctor who you've seen is most likely to be giving you an appraisal of the best evidence-based treatment available to date. And obviously, some patients find it helpful to join support groups, and others prefer to avoid talking about, WM. I think your own WM support group has got some really useful information there, and that's likely to be very valid and solid and go along with current thinking. So just a little bit as time goes on, the disease, as most of you are very well aware, is often indolent, so symptoms may not get worse or require any treatment for quite some time. You're going to meet many healthcare professionals over the years, and I think sometimes establishing a consistent and trusting relationship can feel quite difficult. But it is important to remember that all of your care is likely to be provided by a multidisciplinary team of different specialists who will meet regularly to discuss patients. And if you do see a more junior doctor when you go along, they'll always have a consultant to call upon and will probably have discussed before they even see you what they're going to say and let that more senior doctor know what the outcome is. So I think that's half an hour. So thank you all very much for listening. And I'd be delighted if we've got Bob back to hear any questions that you might want to ask.
Well, first of all, Dame Lesley, I've been making notes while you've been speaking, and it's so reassuring that the information you've given us sort of ties in with what we at WMUK the information we try and give our community, from the things with active monitoring, how that can be a problem for some, the second opinion, the multidisciplinary team meeting, all those points you've raised are things that crop up all the time. So thank you so much for covering those. I'm just going to ask everybody, I see David has already put his hand up, but for the rest of you guys, if you've got any questions, if you go to the bottom, there's a reactions button. And if you press the reactions button, there's a little thing that says raise hand. And if you do that, you'll join the queue. So I'm going to start off with David Lee, if you come off mute and ask your question. You're still on mute, David.
Yeah, I've lost my picture. Can you hear me, Bob?
Yeah, we can hear you. Yeah.
Okay, my question, I'm very interested in the recording of the consultation. And if the person refuses, where do you go from there?
Now, there's an interesting comment. I'd be very surprised if a doctor refused, because it is quite common now for people to actually do that. I'd actually ask them why they would be worried about recording, because I'd be, frankly, a little suspicious of somebody who didn't want what they were about to tell you, that you were going to make some life-changing decisions around, if they said that they didn't want you to record it. There are many, many publications now in different areas of how helpful patients and their families find doing this in terms of understanding more about the rationale and the logic for the different treatment options that they're being offered. So I think that would be a case where I would actually probably ask, first of all, I'd challenge, could you tell me why you object to me recording? And do you have a colleague who I could speak to who wouldn't mind me recording?
Thank you,
And
Dame Lesley. And
if that fails, David, give me a ring and I'll come and sort them out for you.
Oh, okay.
Anne Doman, take yourself off mute.
Yeah, hi. Yes, it's a bit about building up relationships. I find it particularly hard now with having phone consultations and not knowing who on earth I'm speaking to, not knowing what they look like, and the way they approach the phone consultations, they don't always encourage a conversation.
Oh, Anne, you know, I'm really with you on that one. I think the sooner we can get away from these sorts of ways of communicating with people, the better, especially when it is complex and actually anxiety-provoking sort of content. I mean, one of the most important things, of course, from a doctor's point of view, is that you need to look at the non-verbal cues that your patient is giving you. Do they look as though they're with me? They understand, you know, what I'm saying. Have I got to go over that bit again? Are they obviously getting very distressed by this? And I think that if you can't see somebody, it's very hard to adopt a sort of a more compassionate and comforting as sort of relationship with them. Sometimes, of course, people do find that they're helpful because not all of us live close to the place that we are actually being treated. And traveling can be, you know, quite sort of tiring, especially if you're unwell and undergoing treatment that is giving you lots of side effects. I think sort of trying to ask as far as possible if at the very least you could do like this, a Zoom call, although that's got some problems as well. I mean, in fact, I do presentations on how to do Zoom consultations with patients for doctors themselves. But I just agree with you. I think it's here to stay, sadly. There are some benefits associated, but I don't think people should be told particularly difficult and challenging news over a phone call with no facial sort of recognition.
Thank you, Dame Lesley. Joy, you're next up.
Thank you very much for that. It's very interesting. One comment and then my question. My comment was just that the hospital I go to, the Marsden, sends out letters to which I find really, really helpful. And I think it says that apparently I asked for them. I don't recollect doing that, but it may be worth telling patients you can ask to have a letter sent to you with all giving you all the details. And I found that really helpful. My question was about, you talk about people being optimists or pessimists. Does it matter if the doctor you're seeing is an optimist or a pessimist? And does that influence how they present the information to you?
Oh, Joy, yes, most definitely it does. And one of the things that we've been doing recently is some work where we've been measuring doctors' own tolerance to uncertainty. And we know that those doctors who are intolerant of uncertainty are much more likely to suggest to patients that they have more treatment earlier than they perhaps would always need according to other colleagues, because they hate uncertainty and are probably, you know, sort of less optimistic as a result of that. Yes, when we analyze doctors and nurses consultations with patients, the nuance is always very different if they are a pessimist or more likely towards being optimistic. Generally speaking, most doctors can only survive working in difficult areas if they are slightly more optimistic. I did once try and write a paper called Doctors Need to Believe in Miracles Too, because obviously it's hard if you deal with, particularly some doctors deal with certain diseases that have a very, very poor prognosis and where there are very inadequate treatments, and having to constantly every day have these really hard consultations does make them either become sort of burnt out or they have to be overly optimistic about things. But yes, you can usually tell whether somebody is a bit gung-ho in a way that isn't appropriate. But I think sometimes rather than having somebody who's all doom and gloom, I'd like somebody who's a little bit more optimistic. You remember that bit that I said where, you should always ask for best and worst scenarios and outcomes, and then at least you can all hope for the best one and be prepared for things that perhaps don't pan out quite as you hoped. Thank you for that question, Joy.
Thank you, Joy. And Quentin, although I suspect it's not Quentin that's going to ask the question. Take yourself off mute.
I don't know what you mean.
No, I don't know what you mean either.
It's a bit of a follow-on, really, from the last question. Should not the MDT process allow for different doctors' attitudes to uncertainty, sort of iron out, so you get a kind of generalized reaction opinion as to how you should be treated?
The best, most functional MDTs, that would probably be the case, yes. But whilst the MDT is likely to have people from all their areas of expertise, all the different disciplines, coming up with a plan, a management plan that they all agree is probably in that patient's best interest, it's still for one individual usually to present that to the patient, and that individual will sometimes give a more positive or more negative slant depending on their own, sometimes unconscious biases. But I think that, the best MDTs actually are likely to present to you a picture that will be perhaps a little safer than one individual doctor working on their own might give.
Thank you.
Thank you, Dame Lesley. A question just came up. What is an MDT? It's been answered. Could you just explain for those of us that don't know? I try and explain it all the time, but if you can just, and then I'm going to come to you, Nicola. Yeah.
Okay, so for some time now, all cancer treatments should be actually managed via a multidisciplinary team. And this means that certainly every new patient is discussed by people like a radiologist, a pathologist, a surgeon, an oncologist, a hematologist, a specialist nurse, maybe a palliative care physician. All these different disciplines come together. They look at a presentation of all the scans or the blood results or the pathology results, and together discuss what would be, from their point of view, in the patient's best interest to suggest. That could be definitely one particular treatment. It might be involvement in a clinical trial. But at the end of the day, the person who then actually delivers that suggestion on behalf of the MDT still has to have your sort of ultimate decision as to whether that's an option you wish to follow. Not only do we have the management of all cancer now by multidisciplinary teams, there is a sort of common, if you like, zeitgeist that we should all have shared decision making with patients, and some people only pay lip service to that. But a good, well-functioning multidisciplinary team, you have got the security that several people have discussed it. I would just say, however, though, that for rarer cancers like WM, it's difficult to find sort of a large number of experts who are going to be able to have lots of knowledge about the disease and treatment options. However, they all are going to follow common protocols, common management policies that have all been looked at and approved by NICE within the NHS. I think, although we bash the NHS a lot, I think we're a bit safer with that sort of system than you might find in the US or in some parts of other parts of Europe, where you've still got single consultants working out of an office who will only give you their opinion.
Thank you. Just following on from that, Dame Lesley, and I hope I'm correct. I think I know I'm correct. But for those of you who go to more rural hospitals or more rural centres, the MDT, I'll give myself as an example. I live in Bournemouth. Helen McCarthy is consultant, and I know that she chairs the MDT for Bournemouth, Poole, and Dorchester hospitals. Within one sort of region is covered by the MDT. Do you agree with that, Dame Lesley? Yeah.
That's right. You can have virtual MDTs, particularly if, as you say, there are rural sort of communities, or it is an area where within one hospital there isn't sufficient expertise. So there's a sort of a collaborative one that forms.
Thank you. Nicola?
Can you hear me or not?
Yeah, for sure. Yeah.
You can, right? Okay,
Yes.
sorry, microphone problems. Okay, really, I just wanted to go back to the conversation about telephone consultations and ask the question whether there's a best practice guideline within the NHS. It seems to me, I mean, I sit outside my consultant's room, I can see they have video conferencing facilities, but actually they don't seem to use them. It's kind of like, I've got kidney complications at the moment, so I'm also dealing with a kidney consultant, but he prefers to talk to me on the phone, so you don't have that chance to build the relationship. I mean, can you ask for a video consultation, or
I see no reason why you can't ask for one. Some hospitals do have problems with the security sort of barriers to video. I mean, obviously, you will all be well aware that sometimes people have to conduct quite intimate sort of consultations with people. During COVID, there were situations where people had to sort of undress in front of a video so the doctor could see, you know, a lump or a lesion. And there are all sorts of rather concerning sort of privacy issues, because whilst the hospitals might have all sorts of security blocks, most of us working at home don't necessarily have those. So I think there's some protections. I think some people, though, use it sort of just as an excuse not to actually share their video. Maybe they haven't had a shave, or they haven't actually got their shirt and tie on, or whatever. I see no reason for not asking for one.
Thank you.
Thank you, Dame Lesley. We've got 9 minutes left, so I'm going to take 2 more questions. So Sarah Jakeway, take yourself off mute.
Hello, I got my first consultation. I've just had very recent diagnosis, and I've got a consultation on Monday, and I read on the WM website about clinical trials. My consultant, having seen her once at initial sort of stages, does seem to be one of the more concerned over her face mask, slightly worried. And so am I right in thinking that I can ask about clinical trials and whether I can get on any if she doesn't suggest it at that meeting?
Okay, well, that's interesting, Sarah, because obviously I don't know anything about your actual situation. It might be that when she and her colleagues have looked at all your bloods and scans and other results and everything, it's stark staringly obvious which treatment would be the best one to suggest to you. And clinical trials are not always necessarily the right option for everyone. Obviously, we only move forward with knowledge if we encourage people to go on a clinical trial, but some of them have criteria, eligibility criteria, which means that you'd have to be a certain age, certain sort of blood counts would have to fit into the eligibility. Not everybody is suitable for a trial, but there are plenty that are out there in specialist centres. But as I say, it could be that you're somebody for whom it's just stark staringly obvious what you ought to be offered, and that a clinical trial might not necessarily be in your best interests. Having said that, though, sometimes a trial is a very good thing to be invited to. You're going to get lots of monitoring. It shows that you're in sometimes a really good group if you are offered a trial, because you've fulfilled all the eligibility to be asked to be in one. So, for example, people who have got other diseases, let's say you've got diabetes or heart disease, that would render you sort of ineligible for many trials, not all, but most. So I'd sort of, sort of just ask her whether, the treatment or what she's going to suggest in management terms that she's going to suggest for you is the only one, and whether or not there's something else that a clinical trial might offer.
Okay, thank you.
You, Sarah, I've just sent you an email, sent you a message with my email address. Send me an email with your phone number and I'll give you a call tomorrow. And final question is Michael Scrutton.
Hello. This follows on a few of the comments already made. I wonder why FaceTime isn't used more for consultations. It seems to me very easy to telephone. It's somewhere between a phone call and a face-to-face, and it seems not to be used much when it perhaps should.
Michael, it's all again down to security, because it's difficult to stop other people jumping in and listening and hearing. Nearly always, if they don't use something, it's because it's really not a secure system for actually having a quite intimate discussion with somebody about your own sort of medical sort of history and so forth. Not everybody would want that. I don't think many healthcare sort of organisations in this country would permit it.
No. Thank you.
Thank you. Thank you, everybody. So, Dame Lesley, thank you so much for giving us an hour and 20 minutes of your time tonight, because I told you for 20 minutes before we started and discovered that you live near me in Bournemouth sometime. So I look forward to meeting you for a coffee down there. Thank you so much. This is the comments have come up. This has been an amazing webinar, and it's on a subject that really does mean something to everybody on this screen. I know that. It's been recorded, and I'm sure a lot of other people are going to look at it, because you've given us some great advice and some great tips on how to talk to our clinicians and our teams. So thank you so much for joining us tonight. Really appreciate it.
My pleasure. Good luck, everybody.
Thank you. And